Hello and welcome to today's webinar, Alternative Payment Models and Risk Bearing. My name is Samantha Holvey. I'm the Director of Community and Education here at WEDI, and I'd like to take a moment to go over just a few administrative details before we get started. As you have noticed upon joining the webinar, everyone has been placed on mute for the presentation. At the end of the presentation, there will be a Q&A session. In your GoToMeeting control panel, you'll see a questions box. Please type your questions or comments into the field and hit enter. The recording of this webinar, along with the slide deck, will be emailed to all registrants following the live webinar, and you can actually go ahead and download the PDF of the slide deck from the handouts portion of your GoToWebinar control panel. Without any further ado, I would like to hand it over to today's fantastic speaker, one of the Payment Model Workgroup co-chairs, Adele Allison.
Thank you, Sam, and thank you, everybody, for joining us today. We're going to talk about alternative payment models and risk bearing, and this is kind of a part 3, the way I see it. There's 2 other webinars that are out there on demand, and I invite you to take a listen to those as well, but this is kind of getting into advanced economic models as we move into value-based payment. Recent metrics have shown that over 34% of health plans are making payments based on value through an APM, and that number is growing. So to remain competitive, plans and providers have to really move into these new ways of both delivering and paying for care, one that's driven by analytics over transactions, by that measured value over volume. And so regardless of whether you're joining us today as a health plan or a member of a provider community, we're going to explore alternative payment models, risk, and considerations that you may want to have as you contract. Now, WEDI always gives their standard disclaimer. This is totally informational, so this doesn't reflect on the opinion of WEDI as an entity. And the information that is contained herein is current as of today. So it should be accurate as of this moment. So here's what we're going to do. We're going to talk first about value-based categories. Now, this is something I commonly do, so if you've been on any of my other webinars, it may be a little bit redundant, but it's a level set just to frame out how to think about value-based payment. Then we're going to specifically dive into the alternative payment model archetypes, the primary ones. So, of course, you know, depending on your market and how progressive they are, you can get some really wild models out there. But the challenge is in administering those or operationalizing them. So we're going to specifically dive into the 3 most common APM archetypes and talk about those just a little bit. And then the next thing we're going to talk about is risk bearing, whether, you know, you should be bearing risk or you're not ready to bear risk. And this kind of leads up to our APM maturity assessment. Now, this is a model that was actually developed. There's a white paper that's available through my company if you want additional detail on this. But we're going to touch on assessing your maturity level, whether you're a plan or a provider, to see where you are and maybe things you want to think about getting in line before you leap to the next phase. And then the last thing we're going to cover today is risk contracting considerations. So when you get into negotiations, whether you're a payer or a provider, these are some of the things you need to be prepared to talk about, and you need to understand and have the right information in your hand before you come to the table to put that contract in place. So with that, let's just start off with the actual level set of value-based payment. So the first thing I tell everybody, when you think of value-based payment, it really is a simple formula. So value itself is always going to be a function of the quality of care that's delivered, and quality can be measured a lot of different ways. The most common way that we measure quality today is through process measures, and that's because that data is most readily available on a claim. For instance, there's a population that should be getting a flu shot every year. And I can look at the claims data and see whether that flu shot was built. So that is a process-oriented measures. As data becomes more liquid, we'll start to get into what they term value measures or other types of quality measurement. It's things like maintenance of certification for your boards as a provider. It's ratio of staff to patients, lengths of stay. You can get that off claims, but again, the adoption and use of health IT to create better, stronger processes and reduce safety issues. The other thing that we always have in the value equation is efficiency. Now, the most common measure of efficiency that we have today is cost. Cost is very much driven by resource use. So you'll hear it framed out other ways, but again, as data becomes more liquid, this too is going to look at adoption and use of health IT, whether I am still operating a manual, laborious process that is subject to error, or whether I'm actually automating something using machine learning, things like that to make it more efficient. So these are growing mechanisms. However, if the only thing I'm focused on is quality, I'm not looking at value. If the only thing I'm focused on is cost containment, I'm not looking at value. Value will always be a function of the two. So that said, as we get into the modernization of our economic models in the U.S., value-based care really starts to come into play when we get into what I've got here as category 2. Now, the 4 categories of value-based payment, this was a framework that was developed by the Healthcare Payment Learning and Action Network, which was a public-private collaboration formed by Secretary Burwell back in January 2015. So here we are in 2019. This collaboration is about 4 years old, and I use this for everything. I see it in policy. So if you are not familiar with the 4 categories, I would encourage you to go out there and look on HCP land and become familiar with it. It's a really good framework for thinking of your contractual relationships, either with a payer or with providers. So a category 1 type of contractual relationship is what we're used to. You accept my fee schedule, you file claims, I pay you if the benefit's there and the service was done, and we have, lots of little nuances with that, but there's no adjustment of the payment based on any kind of measurement of quality or value. As we move into category 2, this is where we start to hit value-based payment. So a category 2, I may be paying to have that provider ecosystem put infrastructure in place. And a great example of this was the Meaningful Use Program. It was all about adoption and use of health IT, which basically started to digitize and create large amounts of data in the clinical side of the house, or the patient-centered medical home. It's all about infrastructure. And whenever you put infrastructure in place, you create data. Once I have that infrastructure, I pay for you to report that data to me. Really doesn't matter what it says, just getting that data to me. Again, in the federal side, an example of this is your hospital quality reporting measures, your physician quality reporting system. These are all just get the data to me. And if you report your measures successfully, I'm going to give you an incentive. Now, as we look at MACRA and the Medicare incentive the merit-based incentive payment system, I am adjusting payment differentially based on measurements, based on data, and that's your pay for performance. So at this point, I'm really tying it to measures of quality and value. I'm tying your payment to analytics. You're still in a productivity type of model. The risk is not there. You're going to get paid every time you do something, but how much you get paid, either in the form of an incentive or a bonus, or even a penalty, like under the MIPS program, is going to depend on how you measure up. So we do enter value-based payment in Category 2, but we do not enter risk-bearing. Risk-bearing really starts to come into place when we enter into Category 3 and 4 types of contractual arrangements. And this is where your alternative payment models are. So the big mental shift from a Category 2 to Categories 3 and 4 is I am thinking about a shared patient across the provider ecosystem. So this is where I have a provider type of entity, like an accountable care organization, a clinically integrated network. There's ACHs, CCOs in Oregon. There's lots of different terms for these, but where there's an identifiable legal provider ecosystem, and it contracts for a shared population of patients. Now, that could be for episodic care, that is procedure-based, which would fall under Category 3, or it could be condition-based, which would fall under Category 4, or it could be comprehensive population-based management. But again, as I enter into these models, I am 100% adjusting payment based on analytics, based on measurements of quality and value. So the only one that does not make that adjustment is a Category 1 type of payment. So use the framework. I encourage you to do so. And like I said, the previous webinars that we've had out there, and I'll cite them at the end, if this is new to you, I would encourage you to go out and listen to them. So when it comes to trending, what is going on in our country? Well, this is kind of a look at it. Again, the Healthcare Payment Learning and Action Network, this is that public-private collaboration, they do an annual measurement. It's a survey, and last year's survey, which they always release it in October, so that was October of 2018, they look to see what the gain is in alternative payment models. That is the whole goal of the LAN, is to try to accelerate adoption of APMs. Year over year, they have seen an increase, and these are the metrics as of October 2018. They'll come out with a new set. They're in their measurement process right now. And this includes all your Blue affiliates, your MA plans. It represents 77% of the insured market in the U.S. So it's pretty reflective of what's going on. When we look at Category 1 types of payments, the traditional, that is trending down at this point. It is at about a 41% of plans are making payments that way. When we look at Category 2 payments, which is where I start to adjust, or I pay an incentive for becoming a medical home or anything along those lines, it's been trending up. But as of the last measurement announcement in October, it dropped 1 percentage point. So I don't know if that's the beginning of a bell curve. And where is that payment going? Well, it's all going into Categories 3 and 4, which is where I begin to pay the community of providers for that shared patient. And that means something. That has actually trended up. It's right now at about 34%. Now, that does not mean all of these APMs are sharing risk. I could be in a shared savings type of relationship, such as the ones that have been out there with CMS, the ACO contracts for Medicare Shared Savings Program. The bulk of those have no downside risk. If they create savings and they hit their quality measures, they get to share in the savings. But the bulk of those have not entered into downside risk for overages to a target spend. So understand that this 34%, it doesn't necessarily mean things are that they're in risk-bearing relationships, but that is positioning all of these entities to move in that direction. And we're going to talk a little bit more about that. The common archetypes in the last webinar I did, that you can dive into this a little bit more, for APMs, there's really three common archetypes. One is the shared savings, which we just talked about, which may or may not have downside financial risk. You also have episodic payment. So again, this could be condition-based, it could be procedural-based, it could be payment that is made retrospectively through a reconciliation, or it could be prospective payment. And then you have the archetype for population-based payment. So this is where I'm saying, here's the population, and I'm giving you a certain amount of dollars for a certain range of services. And the newer models that have just come out of CMS are these direct contracting models. Again, I spoke about those in a little more detail in the previous webinar. So if you want to learn more about that, please, they're on demand. I hope you will go and listen to those. There are operational considerations for each one of these models, and these are very often new and emerging technologies within the industry. And I think in one of those webinars, I talk about the Gartner hype cycle. The 5-point hype cycle, anything that's emerging, it doesn't always work when you first put it out there the way you intended it. And you can have what's called the plunge of disillusionment. And if any of you have been through a significant software update or a implementation, you've lived through the plunge. All technology goes through the 5-point Gartner hype cycle. So don't think it's just a single vendor that has these problems. It's just where the expectation and the reality don't quite match up. And there's a lot of factors that influence that. But be aware that some of these technologies, many of them, are new and emerging technologies. Eventually they will hit mainstream, the plateau of productivity where they will be commonplace, just like you've experienced with e-prescribing and some of these technologies that have been out there a while. But those are the architects. So let's move into talking specifically about risk. Again, I don't know the level of understanding of my audience today, so I'm going to get kind of basic. But, the question is, at risk, really, what does that mean? And, I've got this nice little picture here that is a pretty easy statement of who's at risk and who's not, who's the bad apples versus the good apples. But be aware that your payers have been in the business of risk management forever. I mean, that's their business. That's what they strive to assess, understand, control. That's what it's all about. As these payment models that we just talked about begin to shift the risk, the bad apples and the good apples, I'm just going to give you $1 for an apple. You have to decide whether it's a bad apple or a good apple. That risk, I'm giving you all the apples, and I'm giving you dollars for all of the apples. That becomes the provider's burden as we move into these alternative payment models. Again, Category 4 being the most comprehensive risk-bearing models that are out there. That's, where we get into comprehensive payment, population-based payment. So this lines up with value-based payment quite a bit. As we, and populations come to you with baggage, and I'm a part of the baby boomer generation. We are deemed a very indulgent generation, and all of those things that were done in the 60s and the 70s are now coming back to haunt us as we, age into Medicare, and we are not an inexpensive generation. So those are the types of things that you have to consider. So when I get a population, so whether I'm a health plan enrolling a population, that could be a commercial population and those folks are employed, so, they're healthy enough to work. It could be a Medicaid population. It could be a Medicare population. Whatever that population is, they're going to have some level of risk associated with them. So part of that population may be controlled. So where I've got these people that are on the blue side, they are controlled. They're healthy. They live healthy lifestyles. You know, they're heart healthy. None of them have hypertension. They all exercise and do Tai Chi in the mornings, and none of them smoke or do any kind of illicit drugs. They eat their veggies and fruit, and genetically they're predisposed to live a long and healthy life. So I've got a portion of the population that's going to kind of fit that bill, and I'm kind of going to extremes here for illustration purposes. On the other side, I have my exposure. Now, these may be the people who are so much fun to go out with at night, because they do things like drink heavily. You know, they everywhere they go, they're not going to walk anywhere. They're going to find the closest parking space. They don't like to sweat. They love to smoke and do illicit drugs. They love their carbs, and this is one of my personal problems. And genetically, they have the BRCA gene, and they have, they're just going to be an expensive population from a healthcare delivery perspective. So that's my exposure. Now, my choice, if I'm looking at this population, is I can either accept that risk and that I'm going to have to pay claims out, the chips are going to fall where they are, or I can take action. There are some things we can control, like smoking and drinking and obesity. If I can move even a portion of those over to the control side, that's where I have my opportunity. So health plans have been doing this for quite some time. The first thing that's going to happen in an APM, however, is I'm going to take that population that I enroll as a health plan, and I'm going to hand it over to the providers. This is called attribution, and there is a methodology that is used by payers to provide that attributed population to that ecosystem, and then you become accountable and responsible for both the cost of care and the quality of care that you deliver to those patients. Constraints do play into this. So if I'm a provider ecosystem and I'm not aware of the benefit design, for instance, you're giving me these 10,000 patients, but you have an open access network, which means they may not even come to my, CIN or my ACO. They may go with somewhere else because you want to give them patient choice. That could have a huge impact on your ability to control or move someone into that controlled equation. Network leakage, that's part of that open access issue. Again, these are things that health plans have to worry with, but now you're holding that risk as a provider, so you've got to be aware of these types of things. If they go outside of your network, it's kind of beyond your control. A specialist playing a primary care role, is that something that goes on in your network when you have a cancer patient, as an example, or a maternity patient? These are things you've got to think about. Now, the primary methods of assigning populations to a provider community, the best way is patient self-attestation. Some, depending on the plan design and everything else, some of them may ask them to select a primary care provider. Most health plans are trying to associate patients with primary cares. Step with the medical home, trying to make that happen. That's the best way to do it, because the patient is making that conscious choice to go to a primary care. The second thing they do is they look at claims, and they look at the types of claims that have come through on that patient. And then the third is, I don't know where to put them, so I'm going to randomly assign them. Now, when this plays out, this is an example of the Blues of Massachusetts. And I don't know what year this was done, but, the first thing that they did, so this must not be you have to choose your primary care. So in this instance, I'm going to look at claims. And the first thing I'm going to see is, when did they last have a well visit? In the past 12 months, who did they have a well visit with? Okay, it was Dr. Smith. This is Dr. Smith's patient. If I don't have that in this for members in that population, there wasn't a well visit, then I'm going to go back 24 months. Then I'm going to look at E&M codes that are kind of linked to primary care services in the past 12 months. And then I'm going to go back 24 months and I attribute and assign accordingly. Then I'm going to look at prescriptions that were written in the past 12 months, 24 months. You see, and then procedures that were PCP oriented, and then selected specialists, like OBGYN, things of that nature. But they basically, almost a quarter of their patients were still unattributed. So if you don't know who this population is, now this could be everybody that's sitting over there in that controlled network. These are my, under 30 immortals that, things are not clogging up, breaking, and falling off yet. They haven't hit age-related issues. They can do anything. They're healthy and strong, and that could be what I've got here. But that doesn't mean they don't need a primary care. That's how they end up using the emergency room as a clinic instead of the urgent care, or not really identifying hypertension that starts to enter the equation in the 20s, or all of those things that we want for prevention and wellness. So we really want to encourage that primary care model, but at the same time, if this one of these 1 in 4 end up attributed to your ecosystem, you need to know it so that you can do outreach and that sort of thing. So attribution is a big deal. Now, the other thing that happens is we want to risk adjust. So this is where I'm looking at what part of the population is controlled versus what part is not. Now, this is the equation that CMS uses for risk adjustment, payment, and transfer calculations. It's kind of crazy. The actual formula for government-sponsored health plans considers a lot of different factors, but I'm not going to do a talk about this equation. So I'm going to simplify this quite a bit by pulling up what it basically constitutes. So what you have to think about in risk adjustment is it's going to look at the relative illness burden on those member patients that are being attributed. How many of them have diabetes? How many of them have congestive heart failure? Some of these COPD, or both, or all of them, and then relative differences in their age and actuarial value. So it's the difference between those two, and then you factor it against either an average premium. This is how they do risk adjustment for government-sponsored programs like Medicare Advantage, your managed Medicaid. And this is really kind of what some model of this is what should be used when they give you a population. They're going to risk adjust the population because the per member per month rate that I give you for each one of these people, this guy's sick, this one's not, I should be paying you more for this guy than this guy. Now, all of this is predicated on data. So your data matters. And so as an example, and this is, if I've got any providers on the phone, this is a real pain point for health plans, because right now they have to bear that risk. The amount of money that they will receive from CMS or from a Medicaid program will be based on their ability to show, the severity of illness of a population. So here I am on the provider side. I'm being paid under a Category 1 productivity-based reimbursement. It is all about how many patients I can push through the clinic. So, I'm working as hard and as fast as I can getting those claims out the door. They came in for upper respiratory. Oh, yeah, and they're diabetic. So I slap an E11.8 on that claim. I have just told that health plan that I have a well-controlled boilerplate diabetic. And they're going to, based on that, they're going to estimate how much, a diabetic's going to cost me more than a non-diabetic. And I am expecting I'm going to pay around $1,400 to take care of a pretty healthy diabetic. If, in fact, I've got a sick diabetic, I've got someone down here that should have been coded, but we didn't code with enough specificity, look at the difference in the estimated cost. Now, if I'm handing you this patient as a provider ecosystem, and your data does not reflect the severity of illness. And this is just on ICD. So now as we start to think of liquid data and getting EHR information with lab results, I mean, this is when we can get more and more precise, but not if the data is not complete or if it's inaccurate. So this is the key to the future. This is all, the data matters in everything in your future. And so this was just as an illustration. So how do I tell where I am, whether I'm a health plan or a provider, and where do I need to head? Well, we're going to talk about maturity assessment. So health plans, like I said, they've been managing risk. And as they move into contractual relationships with alternative payment models, and they shift that risk, especially as they start to shift the risk, it needs to be where they're setting up that ecosystem to succeed. Health plans either already have in place or are adopting the infrastructure that you see here. So when I look at enrolling a population or checking on eligibility, this matters. So now remember, we're attributing a population to that provider ecosystem. Now, whether it's an ACO, whether it's for episodic payment, or whether it's comprehensive care, capitated rate, I need to know who those patients are. So I get this information through enrollment and eligibility. And this is something that is very, very important, because if I think that a patient's part of a population, or I don't know that they are part of my population, it could really, mess up how you perform, or the information that you're including when you do your modeling and all of that. So health plans, they capture this information in the enrollment process, and there's lots of infrastructure that's in place to capture data related to enrollment. The data is also used to try to do some level of health risk assessment. They have web-based applications because we're getting into the Internet of Things. TTR and MMR, we're looking at things like monthly membership report. This becomes very important when we think of, let's say it's a contract with a managed Medicaid plan. Well, Medicaid has tons of churn. And as we look at states having work requirements and things along those, the concept's great. If you're capable of working, you should, before you receive Medicaid benefits as an adult, you really should be working. Well, that's great, but what if I'm working this month and not working next month? That's going to create churn in the eligibility. What does that do to attribution? These are just the dynamics and realities that you bump up against. So they do some type of a reconciliation to know whether this is someone that they're responsible for. The same thing would need to happen if the provider ecosystem, the APM, was carrying the risk on that. You want to communicate with your membership. That requires infrastructure, financial management. Here, the ability to bill premium, receive payments, and process all of that, whether that's payment that's coming PMPM from a government entity, or whether it's premium billing on a commercial population, that's something I have to deal with. Likewise, if I'm a provider ecosystem, I've got to be able to take in a PMPM. That's is an aggregated PMPM. So how are you going to manage that? Looking at quality performance management solutions, administrative, and you want to capture the more data you have, the more precise you can be in identifying what populations you need to take care of. Getting into HCC, it stands for hierarchical condition category. It refers to a system of medical coding that's used by insurance companies so that they can try to predict the future needs of a population for next year. It's something that's very much used. So this is where I do risk stratification. RADV is a risk-adjusted data validation. So where here the money is coming from CMS, and CMS is wanting to make sure that the patient isn't being shown as more severely sick than they really are. They want to validate, that I should be paying you this higher rate. So they actually go in and do an audit to check on that. Well, what's going to happen, whether you're the contracting payer and you're providing patients to a provider community, or you're a provider community and you're being paid based on that patient, somebody needs to be checking there too. I mean, just validating that you are being appropriately paid for the severity of illness of patients that you have. Counter submissions, this is where, RAPS and EDPS is the method that they submit this, but this is data that helps feed these audits and risk stratification, but that is something that is required in government-sponsored programs. Health value management is really where health plans are going as they shift the risk. They're no longer monetizing the management of health care because they've shifted the risk. Now they're monetizing and managing health, and that's their value statement to the purchaser. So this is where I got to know what the health status is of the patient when I hand them to that provider ecosystem. I need to stratify the risk, and I need to measure the outcome. Once I give them Adele and I know her health status, 12 months later, did they improve her health status? How much money did they spend to do that? Was she happy with it? All of that. Case and disease management, this is getting into population management, quality management, and HEDIS reporting. HEDIS obviously is a quality measurement system, but it's what drives revenue for government-sponsored payers. Care gaps, do I know things? Prescriptions aren't being filled. Wellness and preventive and chronic condition management programs aren't being adhered to. Provider performance, all of this is data and infrastructure. Being able to provide feedback to the provider ecosystem, and then actual administration of the APM. So this is being able to configure contractual statements, which we have on paper, into systems operations. Claims accumulators, what claims that are coming in apply to that APM arrangement. Net variation cost reporting, actual to target when we have those set forth. Payment distribution and reconciliation, and total cost of care. These are the things that health plans are putting in place if they don't already have them. So depending on the maturity of the plan, depending on where they are in their VBP journey, these are things that they're actually putting into place. So let's look to the providers at this point. Now, historically, we've been told again and again and again that providers are not ready to bear risk. They don't have the proper infrastructure, and I noticed we had someone from Mayo. Mayo might be, a big academic center like that, probably is offering their own provider-sponsored health plan. I mean, they get all this. They have the infrastructure. But if I'm ABC hospital system in somewhere USA, the chances that I have that infrastructure in place, either I don't understand what it takes to manage risk. These are the things that really need to be in place to properly succeed under a risk-bearing type of arrangement. So whether that's being handled by the payer and shared, or whether that infrastructure exists, is things you need to be aware of. So, but a recent hospital survey was done by HFMA and Navigant. This came out this month, last month. I'm sorry, we're in July. Last month, and I'm going to qualify this. So they interviewed financial executives. So I'm showing this 72% are saying we're ready. We're going to do risk-bearing capabilities in 1 to 3 years. Let me give you some perspective on this, because that was the headline. As I dove into this, there are, I don't know how many hospitals, 4,000 in the country. This is representative of about 170 executive respondents. So if those executive if it was self-selected in the survey, that's the one thing that I don't know enough about this survey. But they're saying 72% of the surveyed respondents said they have that capability to manage risk. They're ready to do it, and they're anticipating by line of business that they're going to enter, 64% will enter these types of relationships with commercials, 57% with Medicare, 51% with Medicare Advantage. And this was an interesting metric of those. 44% already had or were planning to launch a provider-sponsored health plan. I thought that was a very interesting metric. If you're running a health plan, it's much more likely you're going to have the infrastructure for risk bearing. So I thought that was just kind of an interesting metric. Now, some of the cited strategies, which I very much agree with, is a drive to clinical standardization. That is great in concept. However, not all patients look alike. You're going to have your aberrant patients. So cautionary note on that, I think that's good on standardization. But there will be aberrants, from people will vary from the standard. So as long as, that's acceptable, I think that's a good thing. Focus on cost reduction. Lots of opportunity here. And then this one is a big one, keeping patients in network. If you're creating that value ecosystem, you don't want the patients bleeding outside of it. That's probably a poor choice of words, moving outside of that network. You want them to stay within the network that has the buy-in, has the infrastructure, and is doing things right. So based on this, I recommend that you take a very plotted approach in evaluating where you are in the scheme of things. So this is kind of an abridged version. There is much more information available in this white paper, a full chart that spans 2 pages, but just at a high level, if you're a health plan, looking at early stage formation, mature stage formation, early operation, intermediate stage operation, or advanced operation. I've got metrics here for both plan and provider that kind of outline how to kind of say, well, I'm in, mature formation stage, to kind of quantify that. Active categories of contracting that you'll typically see based on that stage of maturity, either the health plan, contracting with providers, or vice versa. Here, early stage formation, it's all fee-for-service. It's the traditional way. We start to enter into pay-for-performance, incentive-based types of programs at a mature stage formation, and this is for APMs. As we get into early stage operation, you're still going to have fee-for-service because I may only have one contract in place, and I may still have bonusing, but I'm starting to get into, 1 or 2 of my payers, I'm starting to contract under a Category 3 archetype, or the health plan is starting to pilot some of these programs and contract with entities. Intermediate stage, you see more 2 and 3, very limited 1 and limited 4. And 4 is really when we spread our wings on risk bearing quite a bit. And then your advanced stage, you really are looking at nothing but 3 and 4 as far as your economic models. How you move through this, you need to assess where you are and what I need to do to get to the next level. And that's, again, these are additive activities or infrastructure that you need to consider, depending on whether you're a health plan or a provider ecosystem. It's all about assessment, analysis, education of those participants, education of the folks in the health plan that this is what's going on. In an APM, that's what you're doing at early stage formation. We start to develop our strategy. We look at analytics. It starts to become real. We get into contracting towards the end of your mature stage formation. Then we launch. This is where you have your design and configuration and implementation of IT to support that. You model out specific measures. You have data sharing that should be going on between payer and provider. Intermediate stage, this is when we get into quality scoring, shared population health management between the health plan and the payer, performance transparency. This could be peer-to-peer review, or it could even be performance transparency to the member patient. Net variation analytic capabilities and risk adjustment, and then, of course, advanced. This is when you start to denote your best practices because you've got experience. You have enterprise-wide data science that's applied. Interoperability data is becoming more and more liquid, and you're integrating non-healthcare data. This is like it could be shopping data, it could be wearables, things of that nature, and then cost transparency. This is a big one. So just think about this as you try to assess where you are and where you need to get. And the last piece that I'm going to go through here is contracting considerations. So when it comes to best practices, I'm going to really kind of boil this down to 4. The first thing before you go into contract, whether you're a payer or a provider ecosystem, know the population that you're talking about. So the tools that you would use to do this, you would have data aggregators, obviously the ability to do advanced analytics. If you have interoperability, it certainly supports your ability to get into knowing your population and using things like social determinants, other types of data that may be non-intrinsic healthcare types of data. Risk assessment, you want to align with your payer. This may be a process that you can do together. You need to have a provider contractual entity if you're a provider ecosystem. And if you don't have the skill set or the domain experts within your organization, whether you're a plan or a payer, get them. This is a one-time thing that you do not want to start off on the wrong foot because it could just really result in a lot of pain. The things you want to know. You want to know medical cost projections, the risk stratification of the population you're talking about, social determinants, I mentioned that earlier, provider performance and outcomes, because it may be that certain providers do a good job of managing these types of populations, and I want to know who they are. Data gaps, network gaps for certain types of conditions that this population may have, and what is the attribution methodology that will be used to attribute populations to your organization. Then the contractual things that you want to either spell out very specifically as terms and conditions or make sure that there is a clear understanding. Quality measures, and I would encourage as much as possible, especially if you're on the provider side, that you align quality measures across your payers if you possibly can. This will help with administrative simplification. On the payer side, if you align with some of the things that are going on at the federal level or the state level, it makes your providers able to more successfully succeed in reporting quality measures. So I certainly would take a real strong look at that. Timing requirements for data submission, cost projections, and then ultimately which patients will be specifically included or excluded. So for example, we are not going to include transplant patients in our attribution model, or patients that have certain diagnosis or on a certain medication. There may be things that make for the specific including or excluding of a patient type. So you want to know your population. The next thing you want to know is who's responsible for what. So the tools that you want to kind of go through is you understand your workflows. So this is kind of a mapping process. You want to kind of map the provider journey for taking care of this population, the payer journey to understand the workflows that have to, and especially depending on who you are. If you're the provider ecosystem, you really want to know how that's going to flow. If you're the payer, you really want to know how certain processes are going to be achieved. And then what is going to be the journey and the changes in the journey for the member patient. You want to map that out as well. And you want to create some type of matrix on your current capabilities, what's going to be automated versus what's going to be a manual process. Understand that up front so you have an idea of the resource commitment that will be required. Member insurance design can, as we talked about, can have a great impact on this. If I'm a provider and this is an open access plan, that matters if I'm being handed a population. So you kind of want to know those things going in. What you need to know out of using these tools, what are the functional requirements? This gets into reporting requirements, data capture requirements, process gaps that you may have, contractual nuances that, let's say I'm an ACO and I have contracts with all these various providers to contract to that ACO entity. Are there contractual nuances that I need to be aware of? The level of participant acuity on what's going to be required. This is no longer a productivity model of payment. Are they aware of that? How savvy are they? Member provider alignment, and what can be done to strengthen that alignment. And then I would always establish short-term and long-term goals. When you go into your contracting, you want to clearly denote payer responsibilities and provider responsibilities. What is the framework of the APM program that you're putting in place? Is the model going to be retrospective, prospective payment? How's that going to work? Who's going to carry what responsibilities related to out-of-network problems that may arise or will certainly arise. And then this also is where you may want to spell out certain carve-outs or service inclusion and exclusion criteria. So especially for things like bundled payments or anything along those lines. So once I've got that mapped out, the other thing we have to do is deliver care. So we're going to look at care management and coordination. Tools that we want to think about, you need to have very clear policies and procedures in place. You want to think about the network design, and this is whether you're a payer or a provider ecosystem, because I may have one provider that does a high quality outcome at a lower cost than another provider in a certain specialty. You want to think about that. And what are you going to do about that? You have to have an adequate network. What if you have a network gap? You don't have enough primary cares to cover the population that's being handed to you. You've got to think about that. And then what are you going to do about leakage? Things you want to know. The provider value by specialty. Somehow this needs to be put into some type of a scoring or something where you can measure that. Presence and number of health homes is a real important metric as you think about this. There are things that happen when you have medical homes in place. The reimbursement methodology, so those contracts that ACO has to its provider participants, how are they going to distribute shared savings? And then care density of the population that's in relation to the providers that are going to be part of this contract. So where are those patients going today? Is this a change in provider, or how is that provider referring cardiac patients today? Are they referring to a high-scoring provider or a low-scoring provider? These are things you want to understand. This is, from a contractual standpoint, you want to very clearly, if you're a payer, spell out minimum provider requirements, particularly when you're looking at primary care. You also, depending on the model, there may be certain provider inclusion or exclusion criteria that you want to spell out. Another thing that I'm going to say on care management and coordination, this is my cautionary word, and I'm going to do this kind of in a humorous way. Once upon a time, there were 4 imaginary characters: everybody, somebody, anybody, and nobody, and they all worked for Dr. Seuss. Well, one day there was an important job to be done, and everybody was sure that somebody would do it. Anybody could have done it, but nobody did. Everybody got angry about it because somebody got angry about it because it was everybody's job. Everybody thought anybody would do it, but nobody realized that everybody wouldn't do it. And it ended up that everybody blamed somebody when nobody did what anybody could have done. And this is a problem. It's not technical. This is a cultural issue. So it's not just a matter of spelling out those workflows and making sure that the process is in place. People literally have to be accountable for things. And we've all kind of been in this situation, whether it's on the payer side or the provider side. So that's my cultural recommendation is make sure that everybody, somebody, and anybody knows what they're supposed to do. And then the final piece is the actual revenue reporting and compliance piece. So this is getting into things like HEDIS data, reconciliation, infrastructure, payment distribution on the provider side, dashboards, very much interoperability, enterprise-wide intelligence, and financial modeling of the what-ifs, the nuances, so that you can optimize and have ongoing improvement and success of the APM. Things you need to know, what are the plan's compliance needs? Are we looking at taking population for an MA plan, for a managed Medicaid plan, or are there certain compliance issues for a self-funded employer? Historical spend versus target spends. What are the areas of opportunity that exist both on the payer and provider side, and what are the challenges that you're going to face? And I'm sure there will be plenty. Things you want to consider in the contract: surplus and deficit percent sharing, stop loss. If this is the first time you're getting into risk bearing as a provider ecosystem, that may be something that you need to have in place. Payment obligations, what happens if I have an overage in a shared savings situation, or I got to give money back because I didn't hit my quality measures. How are you going to capture data? What is the data you're going to capture? And then how are you going to report data, and what's going to be required, by when? All of that needs to be spelled out in the contract. So those are the four things I would recommend for contracting. We're getting very close to the top of the hour, so I'm going to give you my plug for recruitment on WEDI. I am one of the co-chairs for the Payment Models Work Group. I also serve on the board of directors. Please get involved if this information was helpful to you, or if you have domain expertise that you can lend to the equation. We need you. This is kind of a list of the sub work groups. I am particularly recruiting domain expertise for the Payment Models Work Group. We meet on the, help me, Sam, is it the third Monday of every month?
Fourth Monday.
Should have known that. Fourth Monday of every month from 3 to 4. So if you are interested in becoming part of my work group, we would love to have you. Please just denote it in the chat section, and we'll make sure that information gets to you. Other ways that you can engage, and I would encourage you to do so. Again, this particular webinar kind of pairs up nicely with the other two that I've done this year. One is Care Delivery Redesign Using Health IT, and the other one's Understanding Macromeps and APM. So everything kind of melds together. Those are available on demand. We've also got another webinar that's coming up just 6 days away on getting into genomics for health insurers. So that will be a very interesting webinar, and I would encourage you to join. But even more importantly, WEDI has conferences, and the last one we just came out of the spring conference, it was just such a great opportunity to network with people that are struggling with some of these issues, and you see kind of the domains that get discussed on this. The summer forum is going to be very focused on EDI and API. So the 21st Century Cures Rule and the interoperability and all of the things that are going on about this. If you need 101 information or advanced information, I would strongly really encourage you to join us in Chicago. That's coming up at the end of the month, so please register. And then we also have a fall conference that will be up in Arlington at the beginning of December, so look for that agenda as well. And Sam, I believe that is all I have. Thank you for joining us, and it looks like I have one question. Oh, thank you. I appreciate it, Mike. I appreciate that. But do we have any questions? Comments, suggestions? All
and
right.
I haven't seen anything come in yet, and we're just about at the top of the hour. Another well done act. Of course, all the accolades flooding in. We certainly appreciate you here at Weedy Adele. And if anybody does have any follow-up questions after the webinar, feel free to email me, sholvey@weedy.org. You'll be receiving a few emails from me afterwards anyway, so feel free to reply, and I'll make sure Adele gets your question and we get you information. So thank you, Adele, for this fantastic webinar, and thank you to all of our participants for joining us today, and we look forward to your participation on other webinars. And if you have any questions about upcoming events, feel free to email me and I'll get you hooked in. So thank you again, Adele, and I hope everybody enjoys the rest of their week.
Me too. Thank you, guys.